Hi, everyone. Welcome to this module on advocacy, consent, and decision making with your clients. So this is part of the larger Philadoula training. And this time we're going to go through using the packet because that's what you're going to have in front of you. So I want you to be able to kind of use this training packet in your day-to-day work, right? So it will be a little bit awkward in a PDF form versus being in a slideshow form, but I think in the end, this will be more usable and it will actually show you what you have in front of you. Okay. All right. So I'm going to go ahead and move into the first page here, right? Um, so I like to first kind of talk a little bit about the components of evidence-based decision making with your clients, right? So there are three pillars: the research, client priorities, and the care provider's recommendation, right? So the first thing is kind of looking at the research. What does that current research say? What are ACOG's current recommendations for this? And then looking through like what are your clients' priorities? Hopefully you've had some conversations prenatally about what your client cares about, right? What does this client value most in their birth experience? What does their gut tell them about this decision? When, let everybody leave the room, right? What does their gut tell them? And then finally, the care provider recommendation. So, what does their medical care provider recommend? What is their experience with this sort of scenario? Talk through it. Should be a conversation, right? So there's three pillars, right? We must remember that this evidence-based decision making isn't a perfect model for a number of reasons. One, there's just no right decision. We don't have a crystal ball that will tell us exactly, what we should do. There isn't usually a right decision in some of these like more gray area decisions. These decisions exist within a sociocultural environment and a medical system that includes professional standards, local policy, societal norms, and then a living and working environment, right? So there's like different pressures. Maybe they're unconscious, or they're more structural. So it's hard to kind of pinpoint them. But it's not this decision isn't happening in a perfect vacuum, right? And so you can try your best to take into account those aspects of this decision. For example, like, are they just rushing me because a holiday is coming up, right? Are they saying that I need to be induced before Christmas, even though my due date is, close to Christmas and I'd rather like go after my due date and let my baby go into spontaneous labor? But those doctors, they want to be off for the holiday, right? The research shows that there are so many people, so many more people who are induced and have their babies right before Christmas than on the actual holidays, right? Which shows some kind of bias towards getting people kind of done and over with before that. So take that into account, right? If you're giving birth around like the Christmas holiday or something like that, or Thanksgiving, right? So those kinds of situations can really factor into what options are being presented to you. And they may not actually be presenting all of the options for you. Waiting might be a totally fine option. There also isn't enough research on pregnancy and birth, newborns, the female reproductive, condition, due to questions of ethics and patriarchal society. So we often don't have the research that we need to make true evidence-based decisions. I think some people go into this thinking like, okay, should I get induction? Should I not? Let me just look at the research and the research will tell me exactly what I need to do. And that's just not true. That's why evidence-based decision-making has kind of those three prongs. You need to look at what research is available, what you are feeling, right, about this decision and what your care provider says, and then make the best decision that you can, right? So we use the research that we have, and we hope that some of you will go into researching female reproductive conditions more so that we have the research that we need, and it's up to date so we don't have to make decisions based on old or poor research, right? So let's see. All right. So, talking a little bit about sharing research with your clients, because this is going to be part of that educational support pillar of doula care. Um, just remembering that doulas are not medical providers, we need to be really intentional about our boundaries with our clients. We must respect client autonomy and not work outside of that professional scope. So, we're not really diagnosing anything. But one way we can still support our clients is by offering our clients research, education, and even insight from our own experiences. But we should never be making decisions for our clients. That's a very, very clear kind of client doula boundary, right? Where do you find reliable research to refer your clients to? The first one that I always check is going to be evidence-based birth. They have a website, they have a podcast, all sorts of things. I've put a number of their handouts together in a packet for you to take a look at as you are kind of learning to present this information to your clients. But they do a very good job of bringing together all the research and making it digestible for like the common person. So that's the first place I go. However, sometimes your client is dealing with an issue that maybe isn't so common. So you might have to go straight to some of these research databases, like the Cochrane Review, National Library of Medicine, PubMed, all of these things, right? To go kind of read through abstracts, see if you can find something that relates to what your client is going through. For example, I've had clients, a number of clients who have a rare condition called a Chiari, which generally means that their brain is too big or kind of expanding in their skull. There's too much pressure. Some people need operations for this. Some people it's mild and the operation isn't recommended. But there's like very little research out there about what it's like to have a Chiari and be giving birth, right? And so we did our best to find things in kind of going direct to the source of these science articles. But obviously there was not going to be anything on the evidence-based birth website, right? But that's just kind of an example of like, okay, what do you do when you have a more rare, less common condition? And evidence-based birth does not cover it, right? But first go there because most things related to birth and kind of postpartum newborn procedures is going to be covered in that evidence-based birth material. And so you may even be able to just kind of join their website and use their handouts for your clients to help them make good decisions, right? Where can I find practice guidelines? So I've linked to ACOG, which is the American College of Obstetrics and Gynecology, because that's another thing that you might want to be kind of familiar with, because a lot of hospitals don't actually follow what ACOG recommends. And so if you find that like wherever you are, they're suggesting something that is kind of not in alignment and you're also feeling not great about it, you can always use those recommendations to help advocate, right? You can also look at the WHO recommendations on maternal health and newborn care. So those are good places to also see some more standards, give you some context for advocating, right? Now we're getting to a really important topic. So language matters when you're presenting research, right? There are subtle ways that birth workers and medical providers share research that can undermine a client's decision-making or kind of their autonomy in decision-making. For example, the statements below are a number of ways of saying the same thing, right? So the first is your risk of stillbirth doubles after 41 weeks of pregnancy. Option 2, at 41 weeks, out of 10,000 pregnant people, about 17 will have a stillbirth. This means that 9,983 won't have a stillbirth. In comparison, at 42 weeks, out of 10,000 pregnant people, about 32 will have a stillbirth. This means that 9,968 won't have a stillbirth. And that's a quote taken from the evidence-based birth website. And then the third option is between 41 and 42 weeks of pregnancy, your absolute risk of stillbirth goes from 0.17% to 0.32% chance. These are all the same in terms of kind of their accuracy or reflection of their the research, but how do each of these statements feel different, right? Which one induces more fear, likely? Which one is the most understandable, right? So thinking through how to carefully and intentionally share research as to not manipulate your client in any way, or for you to actually be able to recognize when your client is being manipulated, when when you're in a birth scenario, you need to kind of pay attention to language, right? So from evidence-based birth, how should people and their care providers talk about that risk of stillbirth? It's a difficult topic, right? You want to try to present risks in actual or absolute numbers as opposed to relative risk. Talk about both potential gains and losses. Offer a visual if possible. So, we were just looking through options. So, this at 41 weeks out of 10,000 pregnant people, about 17 will have a stillbirth. So it can be really helpful to use, I think evidence-based birth has this on their website. It's like a page that has 10,000 tiny little squares on it. And then 17 of those squares are filled in. And it's a really helpful representation of someone's risk, right? And so that can really help someone take in the data in a way that's useful to them, in a way that helps them make a good decision, right? So offer a visual if possible. And then focus on the absolute difference between two risks. So in a real life situation, this might look like that second option, right? That 41 weeks out of 10,000 pregnant people, about 17 will have a stillbirth, yada, 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 right? So that is kind of an example of, maybe a way that might be the best way we have so far to represent that data, if you are able to kind of do that along with some kind of visual aid, right? And some people might have questions about what is absolute risk versus relative risk if we're trying to kind of reflect these numbers accurately and in a helpful way. Absolute risk is the actual or true risk of something happening to you as an individual, versus kind of the relative risk is the risk of something happening to you versus someone else, which can be kind of confusing sometimes. So maybe they're saying, well, 45-year-olds have twice the risk of 35-year-olds for X complication, right? And that could be a little bit, can just take you down the wrong path, might not be an accurate, represent the information in a way that's helpful, right? So the first option too that we were talking about, where it's like your risk of stillbirth doubles at 41 weeks or something like that, that's also not a great way to represent the data, right? Because it's just, you're not saying what you're comparing that to, what number is actually doubling. Well, if it's a really, really tiny risk that's getting multiplied by 2, it's still a really tiny risk, right? And so that's kind of an unfair way of representing the data. So you want to be using absolute risk and being really, really clear about those numbers as applying to an individual, not relative risk, right? Here are some examples of informed consent, right? Or not informed consent. So the first is not informed consent, right? So they're saying, let's break the bag of waters, which is something that they might use to help increase contractions during the labor, right? So just saying, let's do this thing, obviously not informed consent. What if you said, I'd like to speed things up by breaking your water? It's still not informed consent. You're still basically just telling them what you are going to do. And it's also not supported by the research in spontaneous labor, right? Informed consent is a process. It's not a directive. So it's going to sound much more like a conversation. So the example here is, here's what I'd like to do. This is why I'd like to do it. The risks and benefits include this. Your other options are this. Their risk and benefits are, if you choose to do nothing, and this is how likely something is to occur, right? So it's a conversation. There's space in there for your client to be able to ask questions. It's not just a directive, right? It's a conversation. Okay. Just gives you some examples of what it might sound like in the birth room, right? I also like this thing called consent fries to kind of remind us and remind your clients what true consent really looks like. So consent is F, freely given. So they always have the opportunity to say yes or no in the process, right? Reversible. So let's say if they say, I'm okay with you breaking my waters. And then the provider comes back a few minutes later to break their water and they say, actually, I've changed my mind. That is something to be respected. So their decision is reversible. I is that it's informed. So again, we use informed consent. It looks a lot more like a conversation than a directive given. It's enthusiastic. They feel good in their gut about it. And it's specific, right? And by specific, I mean, maybe a client consents to one vaginal exam, but that doesn't mean that they consent to all vaginal exams or even just the next one, right? So it's specific to exactly the vaginal exam that they are consenting to. It's not for the next one or, the ones coming after, right? So this is all very, very important. Obviously, this chart is given for another purpose, but hopefully with me kind of translating what it kind of looks like in the birth room, you'll see how it like very much applies to the birth room as well, right? All right, so knowing that we might not always have the research handy and it might not be very helpful sometimes, how do you actually get the information you need to make a decision in the birth room? So you can ask some questions, right? So, or you might need to advocate, who knows? But the questions you should ask are below here. Let's see if I can zoom in a little bit. One, what procedure or intervention is being recommended? Why is this procedure or intervention being recommended? A lot of doulas love this brain idea to help remember how to ask questions, and they'll teach their clients this model. So B stands for benefits. What are the benefits of this intervention or procedure? R is what are the risks of this intervention or procedure? A are what are the alternatives? I is what is your intuition saying? And N is nothing. What happens if we wait or do nothing? My personal favorite question to teach my clients, because sometimes people are like, I've never done this in the birth room. I'm totally going to forget things. My favorite question to teach them to say is, can we have some time to think about it? If you aren't sure what your specific questions are in the moment or aren't sure what you want yet, this is a perfect question to ask because you gain insight, first of all, on the urgency of the recommendation based on their response. So let's say you ask this question, you're like, can we have some time to think about it? And they say, sure. That means that it's not an emergency. If they say, this is like a really important thing, and it's a little bit more of an emergency, we need you to kind of like make a decision. Let's talk about this right here and now. We don't have a lot of time to wait. Then you know that like what they're seeing maybe with the baby's heart rate or something is a little bit more serious than we thought, right? And so you can get a lot of information based on your provider's response to that question. And then you don't have to remember all of the questions. But I also do love the brain model of asking questions. So it can be an easy way just to give your clients some examples, right? The last thing on this page that I want to point out is that you might have to teach your clients a little bit about advocacy, right? If they're feeling pressured to make a decision and they're not feeling comfortable, they have the right to say, I refuse to give my consent for you to do X, right? Or you do not have my legal consent to do X. Saying stop or no may not be enough, right? So you sometimes have to use the legal language to get the attention of the provider. It's like, hey, I actually said no, and I do not consent to this, right? So you might actually have to say, a full sentence, even though we all know that no is a full sentence, right? But in order to get their attention, you might have to use the legal language, right? So just kind of remembering that they're in charge, remembering that they have the right to ask for what they want done with their body, right? It's kind of a simple thing, but sometimes you get into the birth room or any of these kind of reproductive medical experiences, and that idea goes out the window for some reason. That somehow just because you're pregnant, perhaps then anybody has right to your body, especially these medical providers, right? So we just have to be, you know, upfront and provide your clients with some tools, right? Because they are still going to have kind of the strongest sway in the birth room. So having them speak for themselves with you as a support is going to be the most powerful way to get what they need in the birth room, right? We're really, really trying not to speak for our clients. That can also be pretty disempowering, and it can kind of move us out of our scope, right? And so we're trying really hard to prepare our clients for advocacy and help them advocate for themselves. If we do have a situation where maybe the partner and the client are kind of struggling with advocating for themselves, but you've already talked about some of their preferences, you can definitely look at their birth plan and say, like, here they said that this is what they want, to take some of the burden off them. So you can definitely refer to that, but don't make decisions for your clients, right? So just a reminder of our role here. Instead, we create space for them to discern and ask their questions. We share evidence-based information with them. We remind them of their options and what to expect with each. We remind them of their priorities from prenatal conversations. We listen to and address their fears in the moment, and we share from our experiences if helpful, right? So you're going to have to use your kind of intuition to decide on whether or not it makes sense for you to share from your own experiences, maybe with other clients. So it's just a little reminder of like what our scope is within this process, because you are a small individual within this larger system, right? You also need to remind yourself that you can't control the Western medical system. It's a big institution, right? It's very powerful. So also don't beat yourself up if it's really hard to get what your client needs within the system. That is not your fault. You should not be swallowing all of that fault. It's designed to be difficult. So do your best and try to stay within your scope when you are doing advocacy work in preparation with your client. Okay. All right. The next topic is going to be all about switching medical providers. So the reason why this is part of the advocacy conversation is because if you choose a medical provider or a birthing location that really fits your values, as long as you have kind of the privilege to do so, you're going to have to do less advocacy. So, for example, if you're really hoping for an unmedicated birth, maybe a birth with a tub or something like that in this area, one of the best places to do that is to go to a birthing center, right? Because there's an automatic assumption that you're probably going to do this unmedicated. They're going to be preparing you and supporting you in a particular way so that you can achieve that goal of having a low intervention or an unmedicated birth, because that's what the location is like designed to support, right? Whereas a hospital isn't necessarily set up to support a low intervention unmedicated birth, right? So you're going to have to do a lot more advocacy as a client, as a doula in that location if what the client wants and what is kind of designed into the system or that location, if there's a mismatch. So if we kind of try to head it off from the beginning, like, hey, if this is what you want and your birthing location doesn't really match that, let's see if there's some options of switching medical providers to get the support you need for what you want, right? then you don't have to worry about doing those like difficult advocacy conversations because you've already chosen a birth location that supports that inherently, right? So you can switch if you're not feeling supported at your location. Most people don't know that they can switch practices and birthing locations even late into their third trimester. So I had someone switch at like 40 weeks or 41 weeks from a hospital that they felt like was not supporting their wishes to another one that was a better fit. And they ended up having like a really, really beautiful birth, right? Um, Basically, what they needed to do is to call and establish care with the new practice and transfer their records over. There are some caveats to this. Some practices fill up quickly. So, for example, birth centers tend to do that, home birth midwives, these lower volume locations or providers, you need to make that decision early. So, if you have that, privilege of being able to work with your clients for a long period of time from, early second trimester, perhaps, or even their first trimester, you can really help guide them to the right birthing location for them, right? And that will make the whole birth process easier. You will have less of a chance of conflict. It's just much better, right? How do you switch nurses if you're not feeling supported mid-labor? So first of all, you want to discuss whether it makes sense to switch or just wait for a shift change. Like maybe the shift change is happening in 3 hours and you're like, okay, I can deal with it until then, right? I would rather just not have this conversation. We can kind of avoid it. It's totally fine. And then you're going to get a new nurse, at the 7 p.m. shift change. Often it's at 7 a.m. and 7 p.m. Those 12-hour shifts. But maybe from the beginning of the shift, you realize you're like, we are not aligned, and you're going to see your nurse quite a bit, a lot more than your OB or your midwife, right? So if you need to switch, ask for the charge nurse to come in to make a request, right? In the end, if it ends up being a better situation for both parties, so the nurse and yourself, if you get a new nurse, right? As long as it's possible. Right. And the reason why, it's kind of awkward to bring your own nurse in there and ask for a switch, right? That's why you bring the charge nurse. She's the one that's kind of in charge of the nurses on the floor to see if there's an option for switching to someone who is a better fit for you. Right. So a lot of people don't know that that's even an option. I don't often have to do this, but it is an option for your clients that you should know about. So your reflection questions for this portion is just to kind of think about the differences between birthing locations. One, who would be a good fit for a hospital, who would be a good fit for a birth center, and who would be a good fit for a home birth, right? And you might kind of start naturally sussing that out as you have more clients, right? Of course, financial access is going to be a big barrier for some options. But one of the takeaways from this question just needs to be that if someone chooses the right birth location, less advocacy is needed and the potential for conflict and disappointment is going to be significantly lessened. So, um, you know, build some options for more success. This is just a graphic that sort of shows you who can have a home birth versus who can't have a home birth. So the yes section is going to have here people over 35, BMI over 35 to 40, first pregnancy, GBS positive, complications in prior pregnancy like hemorrhage or preterm birth, vacuum delivery, live in a tiny apartment. That's totally fine. The people that might be in that maybe category that like maybe your midwife will be okay with doing a home birth with you are going to be VBACs. So vaginal birth after cesarean. So if you've had a previous cesarean, some home birth midwives will feel comfortable with that at home, and some of them will not feel comfortable with that at home. If you have gestational diabetes, it kind of depends on the severity. Some home birth midwives will feel that, if your GD is not super severe, that they can totally do a safe home birth. Or maybe because you're having your second baby, there's less risk, right? And then again with breech. So vaginal birth is not very common in the US. So you really want to be with a midwife who feels comfortable delivering a breech baby. So those are all maybes. They're not going to totally knock you out of the running if you really want a home birth, but it kind of depends on what midwife and what their experience is with those things, whether or not you'd actually be safe at home for a home birth. The people that are in the nope category are going to be people with pre-gestational diabetes. So you had diabetes before you got pregnant. It's not because of being pregnant. If you had heart issues, hypertension, active cancer, a T incision from a previous cesarean. So that means that you have both a vertical scar and a horizontal scar. A baby with congenital abnormalities, preterm birth, placenta previa, and some autoimmune disorders. So those are going to be folks that are not a great option. Basically, just anyone who's like a little bit high risk is not going to be the greatest option for a home birth. So you don't want to get their hopes up if they have any of these things going on. All right. So finally, we're going to look at the ARRIVE study. So the ARRIVE study was a randomized trial of induction versus expectant management. And this was conducted to determine whether an elective induction at 39 weeks would lower rates of death, serious complications, and cesareans. What they found was that the cesarean rate lowered from 22% to 19%, and high blood pressure was lowered from 14% to 9%. So what I want you to look at is this list of resources. So I've linked them here. And what ends up happening due to the ARRIVE study is that a lot of medical providers will push an early 39-week induction, even if there are no medical complications taking place. So your homework is going to be looking at this question. If the ARRIVE study came up in a discussion with your clients, how might you talk about it, right? And this is going to kind of refer back to the conversation about like representing the research in an accurate way or not accurate way, representing the research in a manipulative way versus a non-manipulative way, right? So how do we talk about this research? So take a look at these resources. You can do them together, but we're going to talk about it at our second session, right? So we'll do some creative work, try to figure out like how do we deal with this really common situation of a provider recommending a kind of early induction, regardless of someone's like kind of medical status or history at 39 weeks. And what they're saying is they're giving you evidence-based care because they're citing the ARRIVE study, right? So we'll talk about it.